Hello, Assalamu alaikum. It's me, Dr. Muhammad Kazafi. You are watching Dr. Muhammad Kazafi Views, and today I am presenting. Good morning, dear morning, good evening. We are the evening. Today's my topic is very, very important. Although I present such kind of a topic in a different form, but I want to present this as a case scenario. I have a gunshot wound injury to the head, and the patient I have treated, how I treated, I want to present in front of you. And details of the this topic already presented in one of the previous topic. If you want to go through my previous lecture, and you will find that. The 55-year-old man is rushed to the ER after being involved in the altercation, and the physical examination revealed there is a unconscious and actively bleeding from the right forehead wound, and he is breathing spontaneously, hypotensive and the tachycardic with the Glasgow Coma scale score of 8. The right pupil is 6 millimeter with slow reaction to light, and the left pupil is round, regular, and reactive to the light. Careful inspecting the wound, I found that the burn mark and the black powdered material around the periphery of the wound, as well as some brain matter and the bony debris was coming out, which is very much clearly shown from outside. So what would be the most likely diagnosis? Definitely you understand, and I want to describe briefly. Actually, like that, given the patient's history, the most likely diagnosis is a penetrating head injury, gunshot wound to the head, and this type of the injury usually causes a depressed or the comminuted open skull fracture with intracranial hemorrhage and penetrating head injury. The injury may also be accompanied by the black or dark skin discoloration around the entry wound, and this is mainly seen when the gun has been held in very close proximity to the skin, and the gunpowder mark may also be seen in the rifle and injuries where the weapon is held to a shorter distance. Differential diagnoses include any type of the penetrating head injury from a blast or a high energy projectile, sharp nail, and from a nearby explosion, or sharp nail, or any sharp object mm, with the blast, or with the high energy containing, highly kinetic energy containing projectile injury. So the gunshot wounds are high mortality injuries with about 70% of the civilian casualties immediately dying following the injury, and the mortality rates reach 15% in young healthy patient below 40 years, and the 70% in patient above 60 years of age who make it to the hospital. These are more common in male with female, and which soldier worldwide, as well as the higher number of the males being involved in suicidal and homicidal injuries involving firearm compared to the female. As you know, the attributable factors are usually homicide crimes or mortality conflicts in injuries occurring between the age of 20 to 30 years, and attributed factors are usually suicidal attempt in subject of age 60 years and above. This group fares worse than the former age group, and the location of the injury is typically along the right temple in the suicidal attempt compared to the other type of the firearm injuries. What are the my initial step in the management of this case? Actually, the initial steps in the management of the patient must be performed in the different order, but I did like in that manner, securing the patient's airway, and definitely see spine immobilization in unconscious patient is very, very prime and important thing. And maintaining the patient's breathing by a face mask and bagging or by intubation and ventilatory support, and this help in controlling his breathing parameter and also presents a tool to reduce an elevated intracranial pressure. Circulation maintenance based on the described clinical scenario, and the patient is in hemodynamic shock and need rapid treatment. This includes arresting the current source of the bleeding and initiating replacement of the deficient intravascular volume. One should immediately place two large bore IV cannula over a central line or the start fluid replacement, and the central line can also aid in monitoring the central venous pressure. A type and the cross match for 4 units of the blood should be obtained, and the Foley's catheter is placed that help in estimating tissue perfusion via restrict output, input and output charting. The use of the inotropic support may be needed to enhance the patient's blood pressure and cardiac contractility. And as you know, the disability D, for we are checking when we are checking A, B, C, we know the airway maintenance, bleeding control, or bleeding or the blood flow maintenance simultaneously, circulation. We are definitely looking for that, the hemodynamics, but simultaneously the D is coming after that, and which is called the disability. So evaluation and evaluation of the disability, and then the E is coming, and which is called the exposure of the entire body for screening of additional injuries, and should also be performed and include in the primary survey based on the advanced trauma life support ATLS guidelines, which should be completed in fast and efficient manner. Note that one should not forget the seizure prophylaxis. Penetrating head injuries are highly epileptogenic in the acute setting, with the risk more than 50% of the seizure, and the high risk of the delayed seizure as well, roughly 40% seizures control in acute setting, and does not affect the possibility of having delayed seizures in the future. So acute seizure prophylaxis for 7 days plus a loading dose is recommended in the treatment guideline for the management of the penetrating brain injury. As we know, now the next step is coming. What are the questions and that come in our mind while we are taking history from the patient family and the witness present at the scene. So this is very also important, and sometimes it seems to be simple, but it's not that simple as we are thinking that. So we have to ask, were there any other bullet injury elsewhere in the body? Was there involvement in any fight or any violence or any criminal activity? Was the injury acquired in the battlefield? And this help in determining the type or the category of the weapon used against the patient. And is there any history of mental or psychiatric disorder or or suicidal attempt are associated with the worst outcome? So what was the type and the caliber of the weapon used, and what was the distance of the weapon from the victim, and how many bullets injuries are there, and the multiple gunshot injuries to the head are typically incompatible with the life. So was there any explosion or blast at the scene, or was there the direction of the blood or the sharp nail? Where was the assistant standing? Or all of these questions will help in determining the magnitude and the trajectory of the bullet, and it would also help in formulating a proper individualized treatment plan. So As you know, what kind of the radiological studies should we order or consider ordering on this patient, and why? You know, the CT scan of the brain is mandatory in such cases after initial stabilization, and 3D reconstruction is also help in measuring the amount of the bone benefit if planning or potential surgical reconstruction. Ordering other type of radiological investigation depend on the patient's clinical status and the need to rule out other injuries. For example, CT angiography, CTA, or cerebral angiogram to evaluate for fistulas, aneurysm, or we can say the pseudoaneurysm, or rarely to confirm a brain death. So these studies may be needed, especially the bullet path cross major central nervous system vascular landmarks. So the CT with the contrast may be obtained to rule out brain abscess or empyema development, and this typically does not develop at first but rather over a longer time frame. You know, ordering other radiological exam need to be tailored according to the individual patient and a presentation. Obtaining unnecessary exam may waste precious time that can be used in saving the patient's life or vital function, and the visibility or the viability of the brain and the spinal cord tissue compared to the other type of the tissue must also be taken into consideration in such injuries. In a general rule, MRI should not be obtained in case of gunshot wound to the head as residual metallic bullet fragment, and may be displaced by the magnetic field and can cause further injury to the surrounding brain. Interpreting an image in front of the team, it is very important, because as you know that and how you interpret, so you can understand and convey this message to the other. Even though in some exam you should know how to interpret a scan in front of the examiner or the license giver. So as you know, the image shows of the CT scan of brain with the bone window revealing the entry sites of the bullet, as well as the bone fragment and the debris dispersed inside the brain parenchyma surrounding the created bullet in cavity, and these are the multiple scattered pockets of the pneumocephalus, as well as diffuse traumatic subarachnoid hemorrhage. And the scout image of the brain shows a linear skull fracture, bone debris and the fragment are observed, as well as the skull opening created by the bullet. And so the things to look for the CT scan imaging are important. I just want to mention here, was there any involvement of more than one lobe? Involvement of more than one lobe, especially such as the bihemispheric involvement, is related with the poor or the dismal clinical outcome. And did the bullet cross the midline, or was there any involvement of the sagittal transverse or the sigmoid sinus? Involvement of more than one lobe or any of the venous sinus means the injury was you can say the injury was the injury has been a major magnitude, and the favorable recovery and survival is less likely. So was there any exit wound or in the bullet till inside or still inside? So you have to check the position of the bullet, it is inside or outside. And the bullet can be source of the infection or the toxicity, lead or the copper. Although this factor is important in planning treatment, and neither entry nor exit wound were predictor of the outcome. After that, any sign of edema or impending herniation is the differentiation between the gray and the white matter is preserved or not, or you can't differentiate between the gray matter and the white matter. This thing you have to see on the CT scan. Is there any expanding hematoma or subarachnoid hemorrhage? like in our patient there is, and the affected sulci and the perilesional edema, expanding hematoma or subarachnoid hemorrhage on CT scan are all indicator of the necessity for rapid intervention and correction of the underlying process in salvageable cases. So the global loss of the white gray matter differentiation is usually a moribund sign. And is there any accompanied cervical spine injury? Cervical spine injury is relatively rare in that condition, and routinely ordering cervical spine imaging studies such as the CT scan for the patient who sustained gunshot wound injuries to the head are not warranted. As asymptomatic patient, ordering such investigation is reserved for patients with suspected injury to the cervical spine who are symptomatic or unconscious. And was there any injury to the base of the skull or the nasal sinus that increase the chance of the cerebrospinal fluid otorrhea or rhinorrhea, and definitely sequelae of infection or abscess formation? And was there any involvement of the allocant area, for example motor area, sensory area, visual area? And the finding typically means the major loss of the function and disability. And is there any active brain tissue coming out of the wound, nose and area? And the finding typically signifies continuously evolving increased intracranial pressure. So all of these questions can give an estimation of the patient's expected deficit and the disability, and should he survive the acute state. So should you give prophylactic antibiotic, and what are the factors that may raise the incidence of the infection in such cases? Intracranial infection can occur in 25% of the patient following civilian gunshot injury, and most of these occur during the first 30 days follow-up and the associated major comorbidities, and can be expected especially in patients with compromised immunity such as the diabetes mellitus. The most common causative organism is the Staphylococcus aureus, although the other organisms have been found in the culture such as the Acinetobacter species, and definitely the evidence shows that the early surgical intervention reduced the chance of infection and abscess formation, and there was no association between the administration of prophylactic antibiotic and the rate of the development of the CNS infection. Despite this statement, the incidence of the central nervous system infection after gunshot wound injuries to the brain remains elevated, and guidelines on the management and the prognosis of penetrating brain injury and recommended prophylactic antibiotic for all patients with missile head wound. As you know, the antibiotics are recommended especially in the following case where the incidence of the intracranial infection is very high and the presence of the osseous or metallic intraparenchymal fragment and projectile trajectory through the natural orifice potentially contaminated with bacteria and prolonged, for example, hospital stay. And the choice of the antibiotic can be influenced by the following factor, for example bullet type, civilian versus military, size and the caliber, speed of the bullet and the sharp nail. Same way, slow speed of the bullet, which called the cavitation weapon, and it is the civilian weapon, and presence of the sharp nail actually created a dirty wound and may increase the risk of the infection. Fast military bullets are usually hot and are more likely to be sterile, and the surface area of the contact with the tissue, for example knife, have the larger surface area and hence the larger bacterial load according to the class 3. And as you know, taking surgical swab and sending fragments and the debris for the culture and the sensitivity, as well as obtaining the input of the colleagues from the infection disease team will aid in the treatment plan and is of great value. As you know, here we want to the distribution of the type of the infection in each gunshot injury is different, and I just want to describe the mechanism of the damage in the gunshot injury in the brain. Therefore, you know the multiple mechanism involved in the brain damage in patient with the gunshot injuries to the head, and these are such as, like, you know, the primary injury caused by the direct penetrating and shearing force of the bullet itself. Then this include penetrating bone fragment, debris, and the formation of the multiple small channels within the brain parenchyma by bullet and the fragments. And moreover, the negative pressure generated by the bullet cavity and draw contaminated material into the cavity, and the supersonic shock wave injury accompanied by the bullet subject the brain to a higher amount of the kinetic energy, and this wave usually lasts for a few microseconds and is thought to cause injury not only along the direct pathway of bullet but also to the location far away from the bullet pathway. If these locations include the respiratory center in the brainstem, and this cause apnea and death, so other factors that can contribute to the mechanism of injury include the cope and the counter-cope effect. So the secondary injury include the brain edema created from the initial impact and its sequelae. Late mechanism of injury include infection, abscess, bullet or the fragment migration, the seizures, lead toxicity, and the aneurysm formation. The later is highly suspected if the bullet travel through the path of the large intracranial vessel, hence their need for an angiogram in the salvageable cases. And in case where the gun is held very close to the head, pressurized gases and the debris may cause small secondary channels within the brain parenchyma, and the bullet with the low energy may flip, spin and rotate inside the brain, and hence may cause a wider path and the greater damage. Also, bullet crossing the path involving more than one lobe have the greater damage effects, and accompanying the bony fragment and the sharp debris or sharp nails debris will also increase the amount of the injury sustained by the traveling into the different part of the brain parenchyma. The toxic effect of the copper and other heavy metals and the chemical cause harmful and the inflammatory reaction within the brain substance. So the type of the gun, the bullet, and the effects of the injury. For example, the military guns and the missiles are usually are the larger, faster, and cause more damage and are usually more fatal compared to the civilian gun. However, in the generously mentioned series, the military gunshot wounds are carried better outcome in terms of the mortality and the morbidity, probably due to the faster medical response within the battlefield. And what are the indications for the surgery and why? There are many indications for the surgery. These include the controlling the bleed and the decreasing or monitoring the ICP, debridement, and the removal of the bone fragments and debris. As you know, the cosmosis is also important, but the cosmos is when important is very debatable and is according to the salvageable condition of the patient. The majority of the surgical procedures are directed towards the majority of the surgical procedure are directed towards the preventing secondary brain injury. Surgical timing and the type of the intervention must be decided based on the individual patient's presentation. The timing of the surgical intervention depends upon the patient's hemodynamic stability and presenting neurological status, and patient without brainstem reflexes with widely dilated unresponsive pupil, and the patient who had at the least a single episode of cardiac arrest should not undergo surgery. And intracranial monitoring can be useful in unconscious patient in whom there is no focus for the decompression or no sign of the bleeding or evacuation, so that these monitoring devices can also be therapeutic in the management of the elevated intracranial pressure. And in case of the decompressive craniotomy for the severe brain edema, a large craniotomy is advised. And here, the craniotomy or craniectomy can be done according to the given condition of the scenario or the patient, and what type of the intervention should we offer to the patient, and why, and how would we plan it. So I think one should plan a bifrontal craniotomy in case where both frontal lobes are involved, and unilateral decompression in case where the hemisphere is involved, and copious amount of the irrigation with antibiotic are used for the some center aiming to decrease the chance of infection, or the vigorous debridement, removing any devitalized brain tissue, and the bone fragment, if possible, we should remove. Copper in the bullet might be toxic, and the bullet may migrate. So going after the deep-seated sharp nail or debris should not be attempted initially, as this may cause more harm than good, and it may cause more damage to the parenchyma. So going after the bullet and any debris, it's not a good idea. But you can follow or monitor with the help of the CT scan and intracranial pressure devices. So the surgical intervention may be staged, and you can do in different stages, and dealing with the life-threatening risk initially, then staging after the treatment, such as the coiling of the traumatic unruptured aneurysm, or removing deep-seated bone fragment using stereotactic technique or the image guidance for the safer and the better outcome. And there are also been reports for the head sharp nails injuries treated in a semi-conservative way with only primary debridement with favorable clinical outcome. And what are the expected outcome for such patient? In our opinion, actually the patient have been broadly categorized into 4 major groups based on their presenting GCS, and which also help in predicting clinical outcome. The first group, which is the GCS3, and the patient in this group with corresponding CT brain imaging are usually unsalvageable, and unless they respond to initial ICP reducing measure, even if the ICP decrease, they usually have a very poor clinical outcome with survival rate of 0 to 15%. And the second group, GCS between 4 to 8, and the patient in this clinical group also have a poor clinical outcome, but mortality rate are better than in first group, and survival rate in this group were 30%, sorry. And as you know, the third group, GCS between 9 to 12, this group has far better survival as well as the functional outcome compared to the previous 2 groups, and they should be treated promptly and aggressively in order to decrease the amount of the damage as much as possible. And the survival rate in this group was around 61%, and the fourth group, which is the GCS between 13 to 15%, these patients usually only suffer from the functional sequelae, and the mortality rate are usually very, very low, and the survival rate is usually 97% among those patients with the GCS among 13 to 15. So although there are the several grading tools for the correlate and the presenting clinical status of the patient and the outcome, but the Glasgow Coma scale remains the most widely used and accepted symptom along them. The correlation between the Glasgow outcome score and the basal cistern or the CT scan brain in traumatic brain injury can be used in this case, and is a predicted tool for outcome. You know, the long-term functional and the cognitive as well as neuropsychological deficit of the gunshot wound injury can be improved by neuropsychological rehabilitation. What factor you know or we know to weapons and the ammunition might affect for the severity of injury? Speed is very important thing, distance, and then type of gun. Speed such as the low muzzle speed means less than 250 meters per second. Most handguns are in the speed category. Injury is mostly caused by the primary effect of the laceration and penetration. High muzzle velocity such as the 600 to 700 meters per second, and this is a military artillery and cause shockwave damage and explosive intracranial injury in addition to primary effects of the penetration. And the distance, this usually has very small effect on the bullet injury due to the fact that the bullets lose a very small portion of their energy crossing long distance. So the distance does not matter too much in many cases. And the type of the gun and ammunition, military ammunition are greater diameter, hence causing larger cavity and more damage. And in penetrating injury to the head due to the stab wound or attempt to remove the offending object in general, and we should never attempt to remove a knife or the rod causing penetrating injury into the field, and it may be tamponading bleeding vessels, and this should be removal in the operating room in the sterile and controlled environment. So the stab wound injuries to the brain are usually dirty with higher rate of infection, the most likely possible due to the larger surface area of the weapon and comes in a contact with the tissue. Bacterial load is too high, as well as the longer time they may stay in the touch and with tissue is compared to the bullet, which usually have a exit wound. As you know, and I just want to give us some little brief idea about the distribution of the gunshot wound injury and the sharp nail injury according to the location. According to the few studies, they are telling 35% frontal, 17% temporal, 18% parietal, 10% occipital, less than 1% posterior fossa, roughly 9% cranial, and the multiple is roughly 9%. And the type and the percentage of the complication following the gunshot wound, the most common is the meningitis is about 50%, brain abscess then 25%, subdural empyema 7%, cerebritis 7%, vasculitis 7%, osteomyelitis 5%. So, as you know, and here I want to mention a clinical status of the patient's outcome as per the GCS. You know, the score 5 with the good recovery and the resumption of normal life despite a minor deficit. Score 4, those the moderate disability and disabled but independent and travel by public transportation and can work in a sheltered setting. Score 3 is the severe disability, conscious but disabled and dependent for daily support and maybe institutionalized, means admitted in some care center. Score 2, the patient vegetative state, unresponsive and speechless, and after 2 or 3 weeks may open eye but have sleep wake cycle, and it is not a good condition. Score 1, which is a death, and most death actually you can see in primary head injury occur within the 48 hours. And you know, as I mentioned, the correlation between the GOC Glasgow outcome score and the basal cistern status of the CT scan is predicting outcome in the traumatic brain injury. So normal considered where the GOC1, for example, it is roughly, you can say, uh, the GOC2, which is a vegetative state, GOC3, glaucoma outcome score is 3, where the severe disability and moderate disability is GOC4, and the good, you can say, the GOC5. In the higher result, as I mentioned before, is there is a good outcome. I just try to present this case in detail. I hope you like it. If you like it, please subscribe me and share this topic among us. I will present with you in one more case later again. Thank you so much for supporting as much as you can. Thank you so much.